So first, I wanted to welcome everyone to tonight's webinar, To Live with Lupus, We Need to Know About Lupus, presented by Dr. Zineb Aouhab. And my name is Mary. I'm with the Lupus Society of Illinois. And tonight's presentation is part of our educational programs. All of our educational programs this year have been sponsored by GlaxoSmithKline, GSK, and we are really grateful to have their support. We did want to let you know about our next event. It's All In for Lupus Nephritis, presented by Dr. Alvin Wells, and it's coming up on April 27th. Again, from 6 to 7, like all of our educational events, this one is free. It's a webinar, so registration is required because we'll need to get everybody the login information. But you can go ahead and register for that now. We do expect a lot of people on tonight's call, so we'll need to keep the lines muted, and my colleague Torian Jackson will be going through to make sure that all the lines are muted. There will be a question and answer at the end. Because there's so many people, we ask that you either use the chat function that's a part of the app to send in a question. I'll be taking a look at those. Or you can email me a question, mary@lupusil.org, and I will be checking my emails as well. So we'll leave a few minutes for that at the end. And then I wanted to review our disclaimer just about today's presentation. This event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois website. Going to introduce Dr. Zineb Aouhab, who is originally from Morocco and attended medical school at Hassan University of Casablanca. She came to Chicago and completed her internal medicine residency at Stroger Hospital. Dr. Aouhab is currently an assistant professor of medicine, Loyola University Medical Center Division of Rheumatology. Dr. Aouhab is very interested in lupus in general and lupus health disparities in particular. She looks forward to contributing in education about lupus symptom recognition and early referral to rheumatologists. Dr. Aouhab has presented for us several times in the past, and we're really glad to have her back tonight. So without any further ado, Dr. Aouhab.
Thank you, Mary, and good evening, everyone. So tonight we'll be talking about lupus and how to recognize it and how to detect it early in order to prevent complications down the road. Next slide, Mary, please. So a little bit of history. The word lupus goes back to the 13th century. It was found by the physician named Rogerius. It's a Latin word, and he came up with this word because he noticed that a wasp bite on somebody's face looks like what this disease causes, and he described it as a butterfly rash, or now that what we recognize as malar rash or butterfly rash, and that's how he came up with the name lupus. So like the picture that has a butterfly and a wolf, that reminds everyone about the main symptom of lupus, which is the butterfly rash. Okay, next slide, Mary, please. So what is lupus? Lupus is an autoimmune disease. Autoimmune disease meaning the immune system is making some type of proteins that attack our own organs. It behaves as chronic, persistent inflammation in the body that goes all over. It can affect basically any organ you can think of, mainly kidneys, gastrointestinal tract, lungs, heart, joints, skin, and we'll go over those symptoms as we over the next few slides. Next slide, please. So normally, our immune system is meant to fight infections and cancers by making some proteins that we call autoantibodies. Those proteins protect us against infections, but in some situations, this immune system becomes overactive. Instead of just fighting infections, it starts making some proteins that attack our own organs. And by doing that, it stimulates some kind of inflammation in those organs, therefore causing organ damage. Next slide, please. So typical presentation, remember, as we think about lupus, we always imagine a young female. That's the most common demographic. So typically would be age of 15 to 45. So during conceptional age, it is much more common in females than males, with a ratio of 9 to 1, 9 females for 1 male. Lupus is a chronic disease, but most commonly it manifests as episodes of flare when the disease is active and causing inflammation and the person is not feeling well, and followed by some episodes of remission or quiescence when the body is when the person is feeling well and the inflammation stops. So flares and then remission, flares and remission. So that's typically how it's presented. Flares are unpredictable. They can be triggered by anything. Sometimes we're not able to find any triggers, but typically would be stress is a common factor, and then sun exposure is also another strong factor that triggers flares of lupus, as well as infections. Next slide, please. So going back to my definition of lupus, it can affect any organ. So skin, very commonly affected. The butterfly rash we already talked about, so that's the manifestation of skin inflammation from lupus. There are many other type of rashes, and I'm going to go over them shortly. Lungs can be affected. It can cause inflammation of the lining of the lungs or inside the lungs or the airways or the vessels. Yep, thank you. Joints, also very common. So if it affects the joints, it typically presents with swelling of the joints, inflammation of the joints, stiffness of the joints. It can affect the brain. It can cause stroke, can cause inflammation of the linings of the brain or inside the brain, seizures. Kidneys are very commonly and can seriously be affected by lupus. Inflammation of the kidneys can present as leg swelling, very high blood pressure, weight loss, fever, GI tract. So lupus can cause inflammation of the intestine, so diarrhea, belly pain. It can cause inflammation of the stomach, so any part of the gastrointestinal tract. Heart also can be affected by lupus, and it can cause inflammation of the lining of the heart, what we call pericarditis, or inside the heart, what we call myocarditis or endocarditis. So those are all manifestations of lupus. Next slide, please, Mary. So common symptoms, initial presentation, sometimes or most of the time they are not specific, especially at the beginning. So a lot of times we have people just having like fatigue, weight loss, or fever. So they don't pinpoint to any really disease at the beginning. But then later on, as things progress, you can have facial rash, joint pain, swelling of the legs, headaches, sores in the mouth or oral ulcers, photosensitivity, meaning people are very sensitive to the sun. And by photosensitivity, I mean what typically would happen is a person will tell you, I can be in the car just driving for like 5 minutes and then I get a rash on my face and arms that doesn't go away, and it can last like a couple of days, 3-4 days or a week or so. A lot of people confuse this with just being sensitive to the sun when you go or tan easily. Tanning easily can be with fair-skinned people or just being in the sun for a prolonged period of time. But photosensitivity really is having a rash after being in the sun for like 5 minutes. So that would be red flag. Fever, already mentioned it. Chest pain can be a sign of inflammation of the heart, the lining of the heart or lining of the lungs. Shortness of breath if the lungs are affected or the heart again. Color changes of the fingers and toes. So that's what we call Raynaud's. So that's when the fingers, the palms of the fingers turn blue or white when they're exposed to the cold. And I have pictures coming up about this. Seizures when the brain is affected by lupus, blood clots, stroke. Mary, next one, please. There are many types of lupus. The most common one is systemic lupus erythematosus or SLE. Less common ones are discoid lupus, drug-induced lupus, neonatal lupus, and overlap syndrome. So discoid lupus is a lupus type that's limited to the skin. It's a better prognosis because it only affects the skin. Very, very small percentage of people can go on and develop systemic lupus from the initial batch that we had. Drug-induced lupus is lupus that's induced by a drug or a medication. It's important to recognize this type of lupus because the treatment is basically just stop that medication, the offending agent, and then the lupus symptoms resolve. Neonatal lupus is lupus that manifests in newborn of mothers that have lupus. This is due to some antibodies or protein crossing the placenta and causing inflammation in the newborn's body. This type of lupus is also good prognosis because the newborn, with time, typically around 6 months of age, they will get rid of those antibodies from the mother. And that neonatal lupus, therefore, would resolve after typically like 6 to 8 months after birth. Overlap syndrome is a syndrome when you have lupus that overlaps with another autoimmune disease like rheumatoid arthritis or scleroderma or other type of autoimmune diseases. So, and next slide, please. Again, these are the organs that can be affected by lupus. And from now on, we're going to focus on systemic lupus erythematosus because it's the most common type of lupus and the most serious one. Systemic means that any organ in the body can be affected, again, going over skin, brain, lungs, kidneys, joints, spleen, serum. So we have those antibodies or proteins going present in the serum and blood. You can also have anemia. You can have, so anemia meaning the hemoglobin is low. You can have low counts, like low white counts or low platelets. Those are all can be part of lupus, systemic lupus. Next slide, please. So discoid lupus, these are examples of discoid rash. As you can see, it is mostly located to the skin. The rash starts by being red, itchy, and when it heals, it leaves scarring. So you can see especially on the bottom image, you can see the scarring in the middle. So it starts with being red. That means redness means inflammation. Then the redness moves to the edges, and the scarring starts from the center. And later on, when it heals, it moves. It can occupy the whole area that started with inflammation at the beginning. But remember that picture in the bottom. See, the scarring is in the middle. The inflammation or redness is on the edges. When it heals, it usually heals with darkening of the skin around it because the inflammation, when it heals, it causes some pigmentation around. Where do we usually see discoid lupus? We see it in sun-exposed area. And by saying that, that's typically the scalp, the face, the ears. If it affects the scalp, the hair area, it's usually because it is with scarring, there would be loss of hair in that area, and that's what we call bald patches, or alopecia. That's the medical word for it. The good thing about this discoid lupus, as I mentioned earlier, is that most people do not develop systemic lupus. So only about 10% of people would develop systemic lupus down the road. So 90% of the patients will only have skin limited lupus when they have discoid lupus. Okay, next slide, please. Drug-induced lupus, again, just more explanation about those types of lupus. It is typically caused by medication that triggers the immune system. Also with drug-induced lupus, it's typically a very mild form of lupus. So all the symptoms that you get are mild and reversible for the most part. So the most common ones are rashes, so things that you can see like what I have on those pictures on the bottom. So red rash. This is not discoid rash. This is just inflammation of the skin that heals without scarring. You can have joint pain. You can have muscle aches or fever. And the treatment in this case would be just stop the medication that caused the drug-induced lupus, and the symptoms resolve shortly after that. Next slide, please. Neonatal lupus. So this is lupus that happens in newborns. So during pregnancy, some antibodies can cross the placenta to the fetus. Babies can be born with a rash, typically resolved within 8 months. And the rash is, again, like similar to what adults would have. So it's more red and patchy. And the important thing about this type of lupus is that during the pregnancy, it is very important to monitor the mothers that are pregnant and have lupus, especially some that have special antibodies that have the tendency to cross the placenta. And the reason is the baby's heart needs to be monitored because there is risk of irregular heart rate or slow heart rate that may require some interventions before even the delivery. So it is very important to monitor them very closely. We typically refer them to specialized OB/GYN, not just regular ones. They're called maternal-fetal medicine. So they're familiar with high-risk patients and what to monitor in this case. Okay, next one, please. Overlap syndrome is when lupus is associated with another autoimmune disease. For example, lupus and rheumatoid arthritis can be both associated in the same person. Lupus with scleroderma or lupus with myositis. The pictures in the bottom are pictures of patients with different diseases. So the one on the right bottom, or the one on the bottom right of your screen, that's a patient that has rheumatoid arthritis. The difference with lupus is this patient has deformities on their fingers, so their fingers are deviated to the side. We do not typically see that in people with lupus. Lupus does not cause deformities of the hands, and if it does, they're reversible. They're not like permanently deformed. The picture on the bottom left represents somebody who has scleroderma. So this is thickening of their fingers and then hands. It does cause deformity in a different way because the skin, when it gets thickened, it limits the range of motion, and it's shiny. So that's what you see on that picture. Okay, Mary, please. So now, how do we diagnose lupus? So in general, because the symptoms sometimes can be very non-specific, like weight loss, fever, malaise, and fatigue, the diagnosis can take a long time. It can take up to 4 to 6 years, or up to 3 physicians before it gets diagnosed. It can be very challenging initially, and also because it can mimic any other type of disease. It can mimic infection, can mimic other autoimmune diseases. It can mimic many things. We call it the great masquerader because every person with lupus is unique, and you almost never going to have two people with very similar symptoms. There's always variability. Symptoms initially can be very vague and not initially suggestive of any diagnosis. To diagnose lupus, you do need to spend some time with the, the physician needs to spend time with the patient, getting a good history, a good physical exam, and then the blood work. The blood work comes in last because you have to have pre-convincing history or very high suspicion for lupus before you start ordering all of those confusing labs. Mary, please. So what are those labs and what do they mean? So this is what we're going to be talking about over the next couple of slides. Mary, please. So I'm going to keep it very simple. The blood work for lupus can be very complicated, a lot of tests and a lot of uncertainty about what they mean. We generally start with an autoimmune disease panel, and those are screening tests that we check initially. They're very sensitive to autoimmune diseases, but sometimes they don't give you the exact answer you're looking for. Comprehensive metabolic panel, so that screens for internal organs functions, so typically or mainly the kidneys and liver. Complete blood count, because remember when we talked about those organs that can be affected, we talked about the bloodstream and the counts. So we do check for hemoglobin to make sure they don't have anemia. We check for white count to make sure it's not low, and platelets for the same reason. Urinalysis is very important because that screens for kidney function and proteins that can be spilled in the urine. So when there is kidney inflammation, the kidneys spill proteins that can be detected in the urine. That's why urinalysis is very important. If there is any concern, we also check a urine protein creatinine ratio, and that's basically a quantification. It gives you a number of how much protein is spilled in the urine. Mary, next one, please. So autoimmune disease panel, I told you earlier, it's very comprehensive, very complicated, but those are words you may hear when you are talking to your physician about the blood work that is pertinent to your case. So we start with an anti-nuclear antibody. That's the screening test. So this test tells you that if it's positive, it tells you there's something, but it doesn't tell you what it is. If it's negative, it's a good thing if it's negative, because we know we're not dealing with lupus. Basically, if the anti-nuclear antibody is negative, then you should forget about the diagnosis of lupus. Now, if it's positive, then we have to order more specific tests to give us exactly, they are more specific to some diseases. So they'll tell you, oh, this is more suggestive of lupus, this is more suggestive of scleroderma, and so on. And also, of course, you're taking into consideration the clinical symptoms and the history. So those antibodies are anti-double-stranded DNA, or we call it dsDNA, anti-Smith antibody, SSA antibody, SSB antibody, RNP antibody, anti-SCL70 antibody, anti-histone antibody, anti-Jo1 antibody, anti-cardiolipin antibody, lupus anticoagulant, beta-2 glycoprotein, complements. So complements are also some proteins that we check in the bloodstream that can give us an idea. They're typically low when you have lupus, whereas all the other antibodies would be high if there is active lupus. Now, some of them are more specific than others. So for example, double-stranded DNA, anti-Smith antibody, and SSA and SSB, they're more seen with lupus, and RNP, sorry. The SSA, SSB also can be seen with some other diseases, mainly Sjogren's, if you've heard of it. Anti-SCL70 is more specific for scleroderma. Anti-histone antibody, that's an antibody that we see if we're dealing with drug-induced lupus, so medications that can cause lupus. Anti-Jo1 antibody is more specific for muscle inflammation. The last three, anti-cardiolipin antibody, lupus anticoagulant, and beta-2 glycoprotein, those are more seen with the autoimmune disease that can cause blood clots, and that's called antiphospholipid syndrome. But those are all checked as part of lupus. When we test for lupus, we do check all of those because there are some associations between all of them. Mary, please. So anti-nuclear antibody, I already mentioned a few things about it. It's a very sensitive test. So if someone has a negative antinuclear antibody, they are unlikely to have lupus. Now, if they have a positive antibody, that does not mean that they have lupus, but it means that they may have lupus or they may have another autoimmune disease. Because I'm saying may, because there are many reasons why it could be falsely positive. So when you say positive ANA, it doesn't mean that we're always dealing with autoimmune disease. A positive ANA can be present with age. As we age, that protein can be made in the body at a low titer. So it's just hanging in there, but it's low titer, it's not very high. This can be just a false positive and doesn't mean that you have an autoimmune disease. So medications can cause a positive ANA. We talked about drug-induced lupus. Excuse me. But also, medications can cause positive ANA without any symptoms. So you don't know about it unless you check it. Excuse me. If a relative, if a family member has an autoimmune disease, you are more likely to have a positive ANA if you check it, but it doesn't mean that you're going to have an autoimmune disease. Some infections too can cause a positive ANA. So that's why I'm telling you, the ANA is a very non-specific test because of all of those things. You can have an elevation of that titer for any of those reasons, medications or infections or a family member with autoimmune disease and so on. But if it's negative, then it tells you don't have lupus. Okay, so the more specific ones now, so all the ones we talked about earlier, I'm going to go in details into those. So double-stranded DNA, it is very specific for lupus. So if you have that and it's positive, that tells you you are most likely you have lupus as a diagnosis. It is elevated when the disease is active. Sometimes it can go up and down, so it can be high when there are. I can't hear very well. There's a background noise. Thank you. So a double-stranded DNA can go high when the disease is active, and it can get back to being low or normal if the disease is quiet. So it is measured as a disease activity monitoring. We measure the disease activity with double-stranded DNA. Sometimes, not always the case, but some people can have this trend. When they have a flare, their double-stranded DNA is high, and when it's quiet, double-stranded DNA goes back to being low or normal. Okay, next one, please. So complements, we call them C3 and C4. Those are actually consumed when you have an active lupus. Lupus, when it causes inflammation, it consumes complements. That's how it causes inflammation. So if you have an active disease, those complements will be low because they are consumed. It is also considered a measure of disease activity. Okay, next one, please. So Clotting risk tests. So those are the tests that I mentioned on that list earlier that was overwhelming. But because lupus can sometimes be associated with clotting disorder called antiphospholipid syndrome, or APS, that's how we abbreviate it. So that syndrome is defined by the presence of one or more of those antibodies plus a history of blood clot or miscarriage. A miscarriage that may be due to blood clots in the placenta. Those are three tests, and I already talked about them briefly: lupus anticoagulant, anti-cardiolipin antibody, and beta-2 glycoprotein. Remember, so this disease, if you have one of those antibodies, doesn't mean you have that disease. You have to have some other clinical factors. So something should have happened before in order for us to consider those antibodies meaningful. It has to be either history of blood clot, like blood clot in the legs or the lungs, or stroke that's due to a blood clot, or miscarriage that's due to blood clot. And this can be seen in about 30% of people with lupus. Okay, next one, please. So comprehensive metabolic panel is the blood work that I mentioned that tests for the kidneys and liver, because it does give us an idea about the sodium, potassium, glucose, creatinine. Those are all measures of how good your kidneys are. Albumin, liver enzymes called AST or ALT. So those are a measure of the liver function. Okay, next one, please. So next is blood counts. It's so we have white count, we have hemoglobin, we have platelets count. So any of those can go low if you have active lupus. It's actually very common to have those one or more low, and typically gets better when the disease or lupus is under better control. And that's also something that we monitor very closely because that's easy to test, and that gives us an idea about how active the disease is. Next one, please. Urinalysis. So urinalysis can give you a lot of information. It's going to give you an idea if there are proteins spilling in the urine, and that's going to tell you it's going to be concerning for inflammation of the kidneys. You can also measure urine glucose, blood in the urine, leukoesterase, nitrates, or CAS. Leukoesterase and nitrates, those are signs of infection of the urine. And blood, if you see proteins and blood in the urine, that typically tells you that there is ongoing inflammation and you have to evaluate further. Okay, next one, please. A protein creatinine ratio. So protein creatinine ratio is a quantification of how much protein are spilled in the urine. So we have two ways of measuring it. We either measure it on a random urine test, or we measure it on a 24-hour urine collection to measure the proteinuria. Now, infection should be ruled out before you start getting concerned about proteins in the urine. So it's a 24-hour urine collection has a specific, way of doing it. So you have to collect the urine and at home, keep it in a certain temperature, and then bring it to the lab next day. If there are any concerns for inflammation of the kidneys or lupus nephritis, the next step is to get a kidney biopsy, because that's what's going to confirm the diagnosis. Okay, next one, please. Okay. How often do we do the blood work? Typically, the blood work should be checked every 3 months to assure that all parameters are within normal limits. What we don't check all of those tests I mentioned earlier. We check mostly the double-stranded DNA, complements, those counts, the comprehensive metabolic panel that includes liver and kidneys, urinalysis, so urine test, protein and creatinine ratio. Now, this is done typically for people that have quiet disease. If you have active disease, then those tests can be or might have to be done more frequently than that. Okay, next one, please. Medications that we use, it depends on the organs that are affected. We start with anti-inflammatories for typically at the beginning. So if you have joint pain or joint inflammation, anti-inflammatories like ibuprofen, Motrin, Aleve, or naproxen may be enough. Now you have to be careful, because if there is any concern for kidney problems, you don't want to take those medications, anti-inflammatories, because they can make the kidney function deteriorate further if that's the case. Now, if this is not enough, or you have other concerns, then we use corticosteroids like prednisone or Kenalog. Prednisone is a very potent anti-inflammatory medication, and works instantly. So we use it when there is either there are like manifestations that don't improve on the anti-inflammatories, or if there is a life-threatening or organ-threatening manifestation, and we want to stop it right there. That's when we have to use corticosteroids. Anti-malarial drugs like Plaquenil, hydroxychloroquine, I'm sure all of you are familiar with it. That's like, for us, that's like a vitamin for people with lupus, because it treats so many things. It's a very safe profile, side effects profile in general, and many, many benefits to it. We also have quinaquine. That's another anti-malarial drug. Immunosuppressive medications are medications that lower the immune system, and those are used mainly for kidney problems or other more serious problems from lupus. And the most common ones, I'm sure you are familiar with them for the most part: mycophenolate or Celsap. There's azathioprine or Imuran. There's methotrexate, leflunomide, or Rava, cyclophosphamide or Cytoxan, cyclosporin, and tacrolimus. Now, there are some medications that are part of the biologics or the newer ones. And in terms of lupus, we have two of them that we can use. The first one is belimumab or Benlysta, and the other one is rituximab or Rituxan. Okay, next one, please. So anti-inflammatories, they're typically used for fever, headache, or joint pain. They should be used with caution, as I said, if you have high blood pressure, heart disease, or kidney disease, because they can cause other side effects. They can help with the joint pain, but they can cause more severe high blood pressure or worsening heart disease or kidney disease. Anti-inflammatories can also increase risk of bleeding, so it has to be avoided. They have to be avoided in people with that are on anticoagulants or blood thinners, and also in people with ulcers of the stomach, because those can get worse if you take anti-inflammatories. Next one, please. Corticosteroids. Corticosteroids like prednisone, prednisolone, Medrol, Solumedrol, and Kenalog. They can be topical, so like creams and gel and ointments, or they can be oral, like pills. That's the most common ones that we use. They can be intra-articular, so that means injections inside the joint, or IV medications, intravenous. That's when typically used in the hospital when there is either life-threatening complication or organ-threatening complication. It is typically a first-line therapy in very active disease and flares, often life-saving. Now, when we use steroids, we should, however, try to wean them to the lowest effective dose before it starts causing side effects. We do call them, or we like to use this term because it's so meaningful in this case. We call them frenemies. Frenemies because they are our friends at the beginning. They do treat and stop inflammation immediately. They can save lives. But then when you take them for a long time, over the long term, they start causing a lot of side effects like high blood pressure, diabetes, weakening of bones, osteoporosis, cataract, easy bruising, infections, weight gain, which is main concern. So all of those things, if they happen down the road, then you start defeating the purpose of being on steroids. So the bottom line is that they should be used for a short period of time and wean to the lowest effective dose as soon as possible. Next one, please. Anti-malarial drugs are Plaquenil or hydroxychloroquine or quinaquine. They've been used for a long time since World War II, when initially they noticed that soldiers that were on anti-malarials and they used to have joint pain, they stopped having joint pain. That's how the idea of using hydroxychloroquine came about. So those people, because their joint pain improved, scientists started investigating this anti-malarial drug, and it was found to be effective for joint symptoms and skin symptoms. It can also sometimes help with fatigue and aching, but it's not always the case. Very few side effects, mostly toxicity to the eyes. That's very low risk, and it can be prevented by having a regular eye exam. Okay, next one, please. Immunosuppressive medications. So far, we've talked about Plaquenil. Plaquenil or anti-inflammatories and NSAIDs, they do not suppress the immune system. Corticosteroids or prednisone and all of those, they do suppress the immune system. And now the rest of the immunosuppressive medications is on this slide. This is very exhaustive. We can't go into the details of each medication separately, but I try to summarize them in one slide with things that they have in common. They do work by suppressing the immune system. They're indicated where the disease is moderate to severe, so sometimes we don't have to use them when we have mild disease. They are used if corticosteroids cannot be weaned off or are not tolerated or needed to treat lupus. I mentioned their names earlier: mycophenolate or Celstat, azathioprine or Imuran, methotrexate, leflunomide, cyclophosphamide, cyclosporin, tacrolimus. They have a little bit different side effects profile depending on the class, but all of them have risk of increasing infections risk. And there is, for all of them, we need close monitoring of the blood work because sometimes they can irritate liver or counts or kidneys. So we have to keep an eye on the blood work. Okay, next one, please. Biologics, we have 2 that are approved for lupus, one of them is approved, the other one is in process. So the first one is belimumab or Benlysta. So it has been, we've been waiting for it for a long time. It's the first one that has been approved in over 50 years. It typically works for skin disease, joint pain, and fatigue, and it's given either IV monthly or sub-Q injection. There are injections subcutaneously as well. So unfortunately, so far, we don't have evidence that it works for severe manifestations of lupus. So far, it's only approved for joints and skin disease and fatigue. A lot of people like it, and it can prevent them from being on high-dose corticosteroids for a long time. Rituximab or Rituxan, it is not FDA approved for lupus, but it has been approved for refractory disease, and also can help with those counts when they're low, like platelets being low or anemia that's due to an autoimmune process. It can be very effective in those cases. It's given IV every 6 months, and each dose is divided into 2 doses 2 weeks apart. So you get 1 dose, let's say today, another dose in 2 weeks, and you're done for 6 months. Okay, next one, please. Adjunctive measures. I like this slide even more than what we've talked about regarding medications, because some measures can help you prevent flares, and they're very simple, that prevent you from being on heavy-duty medications as well. So sun exposure. Sun exposure is not good for lupus. So they don't get along very well. If you have lupus, you should not be exposed to the sun. If you have to be exposed to the sun, you should apply sunscreen with high SPF, typically more than 30, and even better if it's more than 70%, and broad spectrum sunscreen. So there are sunscreens that have on the front label it says broad spectrum. Those are the ones that you want to use if you have lupus, because they work better in preventing the UV light from getting to your skin. The best thing to do is stay inside or wear long sleeves, long pants, and then apply sunscreen if you really have to be outside. Also, you know, everyone with lupus should be on top of their cancer screening, age-appropriate cancer screening. So mammograms, pap smears, colonoscopy when you get to the appropriate age. So all of those things, you want to be on top of them. You should also get regular dental exams. So cavities should be prevented. Eye exams to avoid complications from lupus medication. So eye exam, we already talked about Plaquenil. We know it can cause, rarely can cause toxicity to the eyes. So seeing the eye doctor at least once a year is always a good idea. Okay, next one, please. More about the adjunctive measures. You want to get your appropriate vaccinations to prevent infections. Now, if you are on immunosuppressive medications, so medications that are very strong on the immune system, you should avoid live vaccines. So live vaccines that we give in boosters, live vaccines, you should not get them while on those medications. And if you really want to get them, you should stop the medications a couple of weeks before the vaccine and a couple of weeks after the vaccine to prevent getting actual infection or complications from the vaccine. We recommend calcium and vitamin D for most people, especially if you're taking corticosteroids like prednisone or Medrol, so steroids, and that prevents bone loss. Now, if you are on corticosteroids for a long time, you should also get a bone density scan, which is a special X-ray to the bone that measures their density and how strong they are. Also, people with lupus should monitor their blood pressure and blood sugars regularly, especially if you're on steroids, because those can make blood pressure go high, sugars go high. So it's important to be on top of it. Next one, please. Now, lifestyle modifications are important for everyone, but if you have an autoimmune disease, they become even more important. It is very important to stay active, physically, regularly active, a regular exercise, activity program, sign up for a gym, or just walking, let's say, every day, or something that you have to do regularly that you like doing to stay active and keep your body balanced. Well-balanced diet is also important. No sugar, sweetened beverages, more fruits and vegetables, less processed food, less fried food. Those are all detrimental to your body, to everyone's body, but especially if you have lupus. Those measures also would help you prevent high blood pressure, high sugars or diabetes, obesity, high cholesterol, and prevent side effects from corticosteroids. Very important. Okay, next one, please. Smoking. Smoking can make lupus symptoms much worse, and it can make medications work less effectively. Even if you take them, they will not work as good as if you're not smoking. So bottom line, smoking is not a good idea for anyone, especially if you have lupus. Sun exposure triggers flares. We already talked about it. Of course, if you're on medications that control your disease, if you stop them without consulting with your doctor, you may cause a flare. It is very important to stay in touch with your doctor, have a good relationship with your physician, and ask before making any changes to your medications. Okay, next one, please. So how do we navigate the health system? There are a few things, and I like those tips because they can come in very handy and be very helpful, very simple things to do. For example, I have a lot of times I see or I have people telling me that, oh, I had a lot of questions at home, but now I don't remember any, and then we don't know how to, there's no way to help if that's the case. So we recommend having like a diary or something that you track your symptoms on, your triggers, history of medication use, side effects or admissions to the hospital, complications, anything that you think you may need or your physician needs to know. It is important to have those things written down on a piece of paper or a diary, and you bring them to your appointments. So that way you're organized in your thoughts and your questions are answered effectively. You should visit your doctor's office regularly, even if you're feeling well, because as I mentioned earlier, some tests to screen for internal organs damage or inflammation or complications, they are important to be done at least every 3 months. So if you're lost for follow-up, then we don't know what's going on inside your body, and we might not know until it becomes irreversible. So that would contribute to a poor outcome. Be prepared to the office visits, write down questions. I already mentioned that. Be honest with your provider. Don't keep back information. So supplements, herbs, over-the-counter medications, all of those things should be mentioned in case there is any interaction with your medications or any concerns that you may not tolerate them or may cause more, can have side effects on your internal organs. Share your concerns in general. Be open and don't keep things back. Just be, genuine and ask any kind of question. There's no question that's a stupid question. All questions are appropriate, and the more information you get, the more likely you're gonna contribute to your best outcome. Next one, please. Now, outside of the COVID era, it is important to bring a family member or friend with you to the office. Now, with the pandemic, we've had some limitations in terms of bringing family member or friend because we want to limit exposure to people. But hopefully after this is resolved, it's always important to have a fresh pair of ears, someone that remembers or has good knowledge about your medical situation, and they can always remind you what the discussion about the physician and also ask questions that you may have forgotten at home, things like that. If you have other health providers outside of the institution where you see your physician, always try to have that information available to your physician so they can communicate about your condition and make a combined decision. You can also take notes during the visit. So if it's overwhelming and there are a lot of things that you're trying to remember from that visit, just take notes. It's very simple and keep it with you for afterwards. If you don't understand something, you should ask for clarification. Don't just assume that you're going to understand afterward or you're going to ask someone else. Just ask right there so everything is clear in your mind before you leave the office. Summarize your understanding of the plan at the end of visit and make sure that you and your physician are on the same page. Next one, please. How often should I see my doctor? As I mentioned earlier, intervals between visits are variable. It depends if your disease is active or it's quiet, in remission, if you're having any side effects from the medications, if your medications are working. So typically, if you have no symptoms and you're doing well or improving, we do visits every 3 months to keep track of the progression of disease and frequency of blood work monitoring and so on. If you are sick or having flares, you should see your physician more often. Because most of the time medications will need to be changed around. And obviously your physician will be the one that will tell you how often you should see them back. Okay. Stress. So stress, I mentioned earlier that stress can trigger lupus. The immune system in general becomes more active when you have during episodes of stress because it becomes dysregulated. That's even without having an autoimmune disease. If you're stressed out, your immune system is dysregulated. Now, when you have an autoimmune disease, it's even more relevant. Stress can be due to a major event that happens or daily activities that accumulate over time. Stress can also, besides making an autoimmune disease worse, it can also make your high blood pressure worse. It can make your diabetes worse. It can cause depression. Okay, next one, please. How do we manage stress? There are many ways of managing stress, but I have a few suggestions here. Hopefully they will come in handy. It's always good to make a list of priorities. Know how many things or to-do list, have a to-do list and stay organized so you're on top of it and you know what to prioritize and what to ignore for the time being. Stick with your plan. Make time for fun. Massages, meditations can sometimes be very helpful. Discuss also with your healthcare provider. If you feel depressed, you should talk about it because there are resources that are available that can make, it can be just like therapy sessions, just talking and biofeedback and things like that, or medications if needed. Find support groups. So support groups are, they can be crucial in when you have where you're newly introduced to an autoimmune disease because you can hear experience from people that have been dealing with the same for a long time and you can compare and contrast. Very, very important to have support groups involved. Okay. We're almost done. So how do I obtain more information about lupus? You can always discuss with your healthcare provider. We have handouts for patients that are very simple and that are reliable. Read more about lupus by going to the library or use a reliable internet website. Lupus Society of Illinois has a great website with all the handy information that can be very simple and easy to understand. And your physician, usually they'll have more accessible or printed handout that they can hand out to you as well. Okay, all right, and I think that's about it. Any questions? So we have a few minutes to go over questions.
We do. Thank you so much. I know that's a lot of information. And we did get a couple of questions. I got some emailed to me. Mary Ellen asks, I have lupus Sjögren's. Have any clinical trials included people with lupus and Sjögren's syndrome that you're aware of?
At the time being, I'm not aware of any clinical trials, but we do have, this is a very common combination to have lupus and Sjögren's together. So Sjögren's is more of it's an autoimmune disease that manifests initially for the most part with dry eyes, dry mouth. And then lupus is what we've talked about. So if you have the combination of those two symptoms and you have blood work that suggests both, that can be an overlap syndrome. And that's what I talked about briefly in the middle of the presentation. Overlap syndrome is when you have two autoimmune diseases. For the most part, they're treated initially the same way. That's a good thing about this type of overlap, because the treatment is can be similar at the beginning. It depends on the manifestations and the clinical symptoms, but for the most part, they are treated similarly.
Okay, and also clinical trials, I can reach out to Mary Ellen with more information on how to find clinical trials as well. So another question is, the warmer weather year-round better for lupus patients, or is the change of seasons better? You know, I've heard a lot of people say that they move to Arizona when they have lupus and they feel better. Is there any medical?
So joint pain in general, as a subjective complaint, it typically gets better when the weather is warm. So cold weather causes more joint pain. We hear that all the time. Now, for lupus in general, you don't want to be in too much warm weather because that goes along with having a lot of sun around. Then you get sun exposure and therefore flares of the disease.
So you really have to make an educated decision for yourself.
Correct. And you have to, exactly, and you have to try to avoid the sun. Now, if your joint pain feels a lot better and you don't notice any rash with the sun, that's okay. That's okay. But if the sun triggers flares for you and specifically more skin rashes and things like that, then it's definitely not a good idea to be exposed to the sun.
Yeah. Okay, so I got a question from Lula. She said, what medications are helpful for pain? She's on gabapentin, but the emergency doctor said that it could be making her feel sick, but it helps with her pain. Is there anything you know about that?
So joint pain in lupus is more, for most of the time, is related to inflammation of the joints or around the joint. So that's what, in general, we start with anti-inflammatories or corticosteroids if it's really bad. But there are other medications that we can use that can be very good with joint pain. The most commonly used one is methotrexate. Now, azathioprine or Imuran are also good medications that treat joint inflammation. Gabapentin is a medication that treats nerve pain. So it depends on what you exactly have. I'm not sure if you have joint pain or nerve pain. Now, there is another syndrome that we treat with gabapentin. It's fibromyalgia. So fibromyalgia is not lupus and it's not autoimmune, but it's a type of very sensitive skin that can be due to just an overactive nerves. And in that case, gabapentin can be very helpful.
Oh, okay. All right, another question. This one's from LaShawn. Is there correlations between allergic reactions inducing lupus flares? And she gives an example. Peanut allergy, person eats candy bar with nuts. Can the immune response that triggers to react the allergen cause lupus flare as well? Is this a reasonable relationship, allergic reaction and flares?
I see. I am not aware of that. Lupus is not a type of allergic reaction. I'm not aware of allergic reaction triggering flares. Now, it could be that if you have a bad allergic reaction, that's some type of stress to your body, and that may trigger a flare. But the relationship, I'm not aware of a strong relationship between the two.
Okay. Here's a question that came in through chat from, it looks like Nicole. She's had SLE for 10 years, and for 2 years she's been on Benlysta. Her rheumatologist is tapering her medications for at least a year. Since then, she's been experiencing hair loss, but no other lupus issues. Could the hair loss be due to the tapering of the medications?
That's a very good question, but I don't know if I'll be able to answer that because, you know, that's a question that needs to take into consideration many things. It's going to depend on the blood work, the pattern of the blood work. Is this, are there signs of, so hair loss can be very non-specific. It's not specific. It can be due to lupus being active, or it could be due to some medications like corticosteroids, for example, they cause hair loss, or methotrexate, sometimes they can cause hair shedding, for example. Now, you know, if you're tapering off medications and you start experiencing hair loss, it could be that lupus is active, but I really cannot tell just based on that. As I said, you really need to have more information, mostly blood work and physical exam. But it sounds like you don't have any other symptom clinically that you feel. So basically just physical exam and blood work in your case. Now, also, hair loss can be due to a variety of other reasons. So if you have iron deficiency, if your iron level is low, that can cause hair loss. If your thyroid is not working perfectly, that can cause hair loss. So it's very non-specific symptoms.
Okay, so she should really talk to her doctor and
Correct.
get the blood and have her take a look. Okay.
Correct.
So here's a question from Dina. Are there any projects or efforts that patients can get involved to help address health disparities in lupus? I don't know if you know anything specific, Dr. Aouhab. I know that the Lupus Society of Illinois will partner with our medical advisory board members on different projects that have addressed the Spanish language community and the African American community, but they aren't our programs. We just partner with other organizations. But we certainly, when we become aware of those opportunities, we certainly promote them to our community. And then I can also get back to Dina as well. There's the NIH has clinical trials and information that gets posted there. So we can certainly take a look at that. Do you have anything to add to?
Not really. I think you answered it very comprehensively. Thank you.
Okay. And then how long do remissions typically last?
That's another good question. So it is very variable. As I mentioned earlier, when I detailed the definition of lupus, the presentation is variable from person to person. The remission too. Some people may have one flare in their life and they go into remission, they never flare again. Others, they may have flares and remission, flares and in remission, they can be like that for a long time or for the rest of their life. It's very variable, and that's exactly why when I said you really have to keep in touch with your physician, because things like that are not predictable.
Right. Actually, I was talking to a patient earlier today, and I mentioned that years ago I spoke to a woman who had that experience. She had one flare, and then she was in remission for like decades. She still saw a rheumatologist, but it really is a strange situation, you know, that some people know.
It is. Definitely. Yeah. It's a unique disease, and it's unpredictable and very variable. I've had a few patients that were even in the ICU initially because of lupus as their first manifestation, and they never had any flares afterwards from like the ICU being completely in remission for a long time.
Yeah. Here, just a couple more questions, if you don't mind, if you have a couple minutes.
That's fine.
Okay, so that was a question from Tash, and here's another one. What are best foods to combat inflammation?
So anti-inflammatory diet, not that it treats lupus or cures lupus, but it's always a good combination to add to physical activity and medications that are needed. So a healthy diet in general would include a lot of vegetables and fruits, and avoiding sugar, avoiding salt, added salt, fried food, processed food, so avoiding all of those. In terms of meat, we recommend fish and white meat in general rather than red meat, and less shellfish, more of a like white fish and salmon. They have good omega-3 lipids and omega-3 and good fat. So more vegetables, more fruits, more fish, less of the rest. That's how I would sum it up.
And Tash, I can also, if you want to reach out to me separately, we had a nutritionist. She actually had MS, and she talked about different foods that could help different symptoms. There's really no lupus diet. There's, but I think inflammation was one of them. So it's on our website, but if you want to email me separately, I can forward that out to you. Then literally 2 more questions, and then we're going to call it a night. Is that okay?
Yeah, no problem.
Okay, so Chris has a question. I was diagnosed with SLE 30 years ago, but never developed symptoms after the initial blood count issue and ANA. Are there other people like me?
Yeah, I just mentioned there are few people that can be in remission for a
Right.
long time.
Time.
But the flares or relapse can always happen. So that's why you have to make sure that you're always monitored in terms of clinical symptoms and blood work, even if you feel well.
Right. Okay, great. Last question. This is from Kevin. Can you explain the box test from Exogen and how it is useful for lupus patients and their doctors?
Say it
I'm
again,
not familiar with
it. I'm sorry, I didn't hear the question, or I didn't understand.
Okay.
What is the box?
The box test from Exogen. I'm not familiar with that either, and I'm not sure.
Box? Yeah, I'm not sure what it means. Is it BOX?
Yeah. But actually, this is one question that I had is, and I don't know if this is what this individual is kind of trying to get to, is that there's the test for lupus, you know, that there's a company that has the test for lupus. The last I heard was, do you use that in your practice by any chance? Do you mind sharing?
No, I don't. No, we don't use it. I don't think we have it available in our institution.
Yeah. So I'm
the
not
ones
sure.
that we have, I mentioned them in the slides that I went through.
Yes, you did. And I don't remember seeing it. I'm kind of half paying attention to the presentation, and I was your clicker today, so I think I need extra applause for that because I'm not usually
definitely
the clicker. I made a few faux pas, but we got through it. All right, that's it for today. Thank you so much for sticking around a little bit late. Thanks to everybody for calling in. I hope everyone joins us for next month's presentation on April 27th. Dr. Aouhab, as always, thank you so much for the presentation. It really covered so much information. If people have additional questions, you can email me and I will get back to you. Thank you so much, and we'll see you next time.
Pleasure.